Welcome to the World of Rare Disease, a show that focuses on awareness and education about rare and complex disorders. My name is Lisa Deck, and I am a Rare New England committee member and your host for today's show. Today, our show features Christina Hartman, who will be discussing the EveryLife Foundation for Rare Diseases. Christina Hartman is a D.C-based policy and advocacy expert with a background in building alliances. Christina is experienced in elevating the voices of patients, parents, scientists, and clinicians to have a positive impact on health and nutrition policy. Christina was attracted to the opportunity to build and lead an advocacy team at the EveryLife Foundation in Washington, D.C., based on her own experience with the diagnostic odyssey and journey with her youngest daughter, Charlotte. Christina currently serves as the Senior Director of Advocacy and Policy for the EveryLife Foundation. Welcome to the show, Christina. Thank you for being here.
Thanks, Lisa.
I wanted you to tell me a little bit about the EveryLife Foundation and how it began. I would love to hear that story.
Yeah, it is a fascinating story. So the EveryLife Foundation for Rare Diseases was started with Mark Dant and Emil Kakis. So Mark Dant in the early 90s, was a police officer in Texas. And he and his wife Jean had a son, Ryan, who was 3 years old. And he was diagnosed with MPS 1, which is a lysosomal storage disorder. At the time, Mark and his wife were told, you're going to have to take Ryan home and love him for as long as you have left, because he's not going to live very long. Now Mark, anyone who knows Mark knows that he did not take this for an answer. Mark started having bake sales and raising money, and he said, I'm going to find a cure for Ryan. And again, he's full-time police officer in Texas. This is the 90s, no internet, nothing. Mark, being Mark, kept raising money, then realized he had no one to give it to. There was no one doing research on MPS 1. Somehow, he ended up finding Dr. Emil Kakis, who at the time was in California in a lab that he'd built with his own two hands, just a small bungalow, cleaned it himself, no financing, nothing. Emil had a pediatric background, and he was very passionate about finding a cure for MPS 1. So Mark quickly moved beyond the bake sales and ended up raising enough money that by 2003, Emil and Mark and the work that they had done led to an FDA-approved therapy, Aldurazyme, for MPS 1. And Ryan is now 30 years old. So Mark Dant is the board chair at the EveryLife Foundation, and Emil Kakis is still sitting on our board, and he is also now the CEO of Ultragenyx, which is a rare disease-focused pharmaceutical company. So two incredibly passionate people, a doctor and a father, came together, and in what is unfortunately not a common story, were able to find a cure, or not a cure, sorry, but a treatment for Ryan that could control the MPS 1. And he goes in still for his infusions, and again, 30 years old.
So I'd love to ask you a little bit about how policy works in the federal government. Just a very basic overview for the layperson, because I will get into what EveryLife does, but I know it's a little complicated for people who live outside of DC. Could you talk a little bit about how policy works?
Absolutely. So many people probably learned in their civics class about how a bill becomes a law. I think we're all generally familiar, but there are three main branches of government. The legislative branch, which is the Congress. It's a bicameral legislature here in the United States. So there are 535 elected members of Congress. In the Senate, there are 100 senators, and then there are 435 elected members in the House of Representatives. So we have, in the United States, 2 senators from each state, and then 1 member of Congress for each district. We also have the executive branch, which at the top is the President of the United States, and there is a huge staff in the White House Many people have seen the TV show The West Wing. There are also two huge office buildings. One's called the Old Executive Office Building, and then another called the New Executive Office Building, adjacent to the White House. And there are hundreds of employees within just the White House. And the entire executive branch is led by the president's cabinet. And those are the secretaries of the major entities. So the one we're probably most concerned with in the rare disease community is the U.S. Department of Health and Human Services, which is led by Secretary Alex Azar. They oversee the U.S. Food and Drug Administration, the FDA, the NIH, which is the National Institutes of Health in Bethesda, Maryland, the Centers for Disease Control and Prevention, or the CDC, based in Atlanta, and then several other agencies, for example, the Health Resources and Services Administration, or HRSA, which is who administers the newborn screening, the federal newborn screening program. So that's the executive branch. And then, of course, there's the judiciary, which thankfully I don't have to deal with too much, and that's the Supreme Court.
Right. When you say there's the two branches, so when you, as somebody who's going to lobby for policy,
Yep.
You're mostly dealing with the legislative branch, correct?
So actually, the interesting thing in Washington is the way you can be most effective is when you create a plan where you work with both the legislative and executive branch. So in terms of exerting influence to really achieve a particular policy objective, it's best when you not only are lobbying your members of Congress on the legislative side, and that can be for legislation that would provide authorizations, or most effective is often going straight to appropriators and getting dollars appropriated, because a lot of people don't realize you can authorize and appropriate at the same time. On the other side of it, if you get an authorization for something in Congress and then no dollars are appropriated, nothing happens. And that's more common than most people realize. In terms of the executive branch, in my history as a lobbyist, we have often exerted influence by going to Capitol Hill and dealing with our elected members of Congress and asking them to apply pressure to the executive branch for specific interests or for specific objectives. And that's very effective because the executive branch needs dollars appropriated in order to function. So they have a real incentive to answer Congress's questions. So typically, we deal with both the executive and legislative branches in pursuing particular policy goals.
Right. Another thing I wanted to just kind of set the scene for as we're talking about policy, and in particular, EveryLife's priorities. Can you talk a little bit about rare diseases and the idea that, there's all these small rare diseases, but together is how we come together to exert influence. Can you talk just a little bit about that?
Absolutely. So in Washington, where everyone has a million priorities, it's really important to be heard. And in order to be heard, you really have to give people a reason to listen to you. So the most effective way of doing this is actually being a constituent of an elected member of Congress. And so one of the greatest things that we can do in the rare disease community is really empower patients to use their voice and to go to their elected members of Congress who work for them. And I think that's important to remember. A lot of times we think, there are these people in this beautiful ivory tower, the capital of the United States of America, but they work for us. So they've been elected by the people in this democracy. And if you don't go and tell them what you need, they can't do anything. But when you use that power and you go into their offices in Washington, at home, in the districts, and you tell them what you need, 99% of the time, they'll help you. So I think that's the number one thing. The other side of it is they do get a lot of requests. So the more requests that they get that are asking for the same thing, the more likely it is that they're going to devote time and attention to getting it done. So the rare disease community, when I first came into this, it seemed a bit fragmented. There are several organizations, all of which are incredible, important. I'm very glad that they all exist. But at the same time, we don't often speak with one voice. So if you're going in to see an aide at the White House, or if you're going to see a very busy staff member for a major US senator, they probably have 10 or 15 minutes in their day that they can devote to your issue if you're lucky. And so if you really want them to make progress, the best way to do it is have a united ask from the rare disease community. Get the community together, figure out what it is you want, and then make that ask. The worst thing you can do is have 3 different people go in, take up 3 hours of someone's day and all ask for almost the same thing, because then they don't know which direction to go in. And again, they are meeting with people on every subject, from the energy issue and climate change to paying for health care, to trade issues. And then the rare diseases is just one tiny segment of their day. So to really be effective, we have to be united.
Right. I have seen that happen firsthand, and I think it's really amazing when you come in with a set message and you bring that to the legislators, because they respond, they know.
Absolutely.
So that's very exciting. Can you give a brief overview of the federal policies for EveryLife Foundation?
Absolutely. So this year, in 2019, our number one priority is ensuring that the Newborn Screening Saves Lives Act is reauthorized. So this act was initially passed in 2008, was reauthorized again in 2014, and this next reauthorization is due by September 30th of this year. So we've been working closely at EveryLife with the March of Dimes to ensure that this bill is reauthorized, and that it's reauthorized with a appropriations request that's appropriate. Apparently, in the past, what was authorized was not enough. So we're trying to raise that authorization level. We're also looking for ways to make it easier for states to adopt the federal RUSP recommendations. And the RUSP is that Recommended Uniform Screening Panel, and it's a group of experts that decides which diseases to add to the newborn screening panel. But once that decision is made at the federal level, individual states have to adopt it. And so this is another thing we're very focused on at EveryLife, is ensuring that there's uniformity between the federal recommendations and then what's happening in each state. So that's one of our major policy priorities. The other thing we're starting to look at, because newborn screening is an incredibly important facet of the diagnostic odyssey, but it's just one piece and it's really the beginning, we're trying to take a look at what's next. So many of you may have heard about a bill called the Precision Medicine Act that was introduced in the last Congress by Congressman Swalwell. We're hopeful that it will be reintroduced in this Congress, and that this time around there will be a Senate companion bill. That didn't happen last time around. The challenge that we have is that the way that the bill was initially drafted, it was specific to whole genome sequencing. Now, many of the clinicians that we've spoken with and many of the groups that we've spoken with, including the American College of Medical Genetics, are concerned that we would be legislating a particular technology. So we'd like to ensure that that definition is broadened to whatever genomic sequencing clinicians think is important for their individual patients. So this is something that we're working on. The whole genome could be a proof of concept, but at the same time, we think it's important, again, if we're legislating at the federal level, to ensure that it would not exclude any other technologies that physicians would like to use to diagnose their patients.
Excellent. So you have those two major priorities. Is there any additional, or is that really what EveryLife is focusing on this year?
So the other big issue for us that we're working on finding a solution for, many of the rare disease community members are very familiar and have been very passionate advocates for the OPEN Act. And this was a bill that had made it into 21st Century Cures, but unfortunately had been pulled out at the last minute. And the foundation and others in the rare disease community have been trying to get this bill passed for over 5 years now. Unfortunately, because of the provision in the bill would essentially provide 6 months of exclusivity for pharmaceutical companies that repurpose existing therapies for rare disease indications. And this is important because so many members of our community are using drugs off-label. So the statistic that we have been using is 95% of the rare disease community does not have an FDA-approved treatment. Some of them.
Can I jump in
Yeah,
for one
absolutely.
quick second? When you say off-label, can you explain what that means? Because I know when I first heard it, I didn't understand.
Yep.
So if you could tell us that.
Off-label means that the studies haven't been done to provide an indication for its use in a particular disease. So, for example, if you have a drug to treat heart disease, but you have a rare disease and a clinician or a scientist thinks that it could apply to your rare disease, they'll write you a prescription for that drug, and that's called off-label. It's not for using the drug as indicated. And the issue with that is then you don't often get insurance coverage. You don't have the right dosing information, safety information, or efficacy information because the studies haven't been done for that indication.
Right.
So it's not ideal. So again, 95% of our patients don't have FDA-approved treatments. Many of those don't have any treatment whatsoever. But then on the other hand, there are some that have treatments, but they haven't been repurposed specifically for rare disease therapies. So the Open Act would have provided incentives to pharmaceutical companies to perform these studies. They would not have received the exclusivity unless they did the studies and the indication actually made it on the label. And this was modeled after the Best Pharmaceuticals for Children Act, which did pass. And it would actually even be a higher bar than that Best Pharmaceuticals for Children Act because you'd actually have to get the indication on the label to receive the exclusivity. But unfortunately, we've been told in no uncertain terms that in this current climate, exclusivity is not going anywhere. And because of the drug pricing debate, many politicians do not want to be seen as assisting pharmaceutical companies. Now, this is very disappointing for us because we don't see this as a handout to pharmaceutical companies. We see this as a dire need for patients. They need treatments. But being what it is, we've realized that, we could waste our time banging our heads against the wall trying to get this bill through, and it is actually going to be reintroduced. And if there's an opportunity to add it to a package and get it through, we will absolutely take that and we will do it. But because, time is limited and many people are running out of time, we've decided to go back to the drawing board and take a look at, in this current political climate, what can we do? What new policy can we put together to incentivize not only repurposing existing therapies, but also incentivize new innovative therapies? It's 35 years after the Orphan Drug Act. I think it's done what it can. We still have a long way to go. Too many people still don't have treatment. So we're going back to the drawing board, taking a look at what's been tried, what can we do, what's possible, put the legislative proposal together, and then we're going to push it forward with an eye toward the next Prescription Drug User Fee Reauthorization Act, which happens every 5 years in Washington. Many bills like that would get added to it. So we think there's some real potential, but it has been pretty disappointing, I've got to say, with the Open Act.
Right. Well, it sounds like you always have to be reinventing and coming up with new ways. And
Yep.
I think it's excellent that we have the EveryLife Foundation to do that for us and
Yeah.
help us and collaborate as a
Exactly.
rare disease community. So that's excellent.
Yes.
I know there's some other events. I know you're in town for an event. Can you talk a little bit about some of the events that EveryLife does in terms of policy and bringing that to patients and patient groups?
Yes. So we have an event called Rare on the Road. And this year, we're holding 4 Rare on the Roads. So one here in Massachusetts at the Broad Institute in Cambridge. We'll also be going to Alabama, South Dakota, and Colorado this year in 2019. And the Rare on the Road event, it'll be my first one this Saturday. I'm very excited to attend. It's an event we do in conjunction with Global Genes, which is another national rare disease nonprofit organization based here in the United States. And the event is really to try to train individual rare disease patients and caregivers and advocates to utilize their stories and their knowledge and their experience to go to their policymakers and advocate for the rare disease community. So giving them the tools that they need and the knowledge that they need to really be effective advocates. And the hope is that once they've attended a rare on the road and there's a level of comfort, that they'll then take the next step and join us in Washington for our annual Rare Disease Week on Capitol Hill, which is, really the biggest event of the year, growing so fast. We had 800 people in town for it this past year. We expect it to be even bigger next year. So really hope folks will come out and join us, and then following that up with our formerly known as the in-district lobby days, but now rare across America.
Excellent. There's so many opportunities to be involved with EveryLife, and it's wonderful that you provide those to the community, to the rare disease community. So thank you again for sharing all of your knowledge and information. It's been very enlightening.
Well, thank you.
Appreciate it.
Thank you for having me.
You're welcome. Before closing, we provide our viewers with an opportunity to share comments or ask questions from our prior shows. Rare New England in Motion is the perfect way to expand upon our mission of engaging with our community. Please send us your comments or questions to info@rarenewengland.org. We will share your responses on our next show. From our last show, we received a question asking about how to become more involved with rare diseases here in Massachusetts. This person had a rare disease and wondered what they could do to become involved. We encourage you to go to rarenewengland.org, and there's many ways to become involved and to contact us if you'd like to be involved in such a cause. That's our show for today. Please let us know your comments and email us any questions you have about today's topic. From all of us at Rare New England and all the patients and families who keep rare disease in motion, thank you for watching. And remember, when you hear hoofbeats, think zebras. Thank you.